says makes the legislative changes arising from the government's response to the Ministerial Review Group, the Horn Report. And I'm pleased to say that the Green Party will support the bill tonight. However, it is indeed a rarity. Yeah. The Horn Report itself was a bit of a mixed bag, sir. I don't think I could share the Minister's glowing praise for that report. While it contained some good analysis, it also contained a significant amount of needless reworking of things that the health sector was already doing, and an awful lot of ideological, structural ideas looking for a home. So we were certainly relieved when the government, in fact, did not proceed with many of the recommendations from that review. This is a bill that sets out to do effectively two things. It overhauls the quality improvement structure that's in the Act, upgrading the structure from a committee, an advisory committee, through to a commission, and it provides the machinery for closer collaboration between DHBs. And so we support both of those objectives. First of all, in relation to quality, the first iteration of the structure was the advisory committee that had the brief of dealing with both epidemiology and quality. An unusual marriage of subjects, and one that, despite the best efforts of those involved and the best intentions behind that committee, didn't really work. That achieved a shot in the arm from the previous Minister, the Honourable Pete Hodgson, and I want to pay tribute to the work of the Minister in establishing the Quality Improvement Committee, on which I had the pleasure to serve for a time. And I think the Quality Improvement Committee did a great job, in fact, in accelerating the quality improvement agenda in health. And I want to pay tribute to Pat Snedden, the chair of that committee, to the other members of the committee, to the ministry staff who supported it, and to all of the DHBs and others in the sector who actually took on board those quality improvement projects, picked up the ball and ran with it, as it were, sir. The last 5 years or so has really seen a quantum leap in quality improvement in health, perhaps starting with Peter Davis's research work that really highlighted the extent of errors occurring in our hospitals. The work of the Health and Disability Commissioner has also been important, sir, in pinpointing the places and the mechanisms involved where things go wrong, and also establishing a culture of open disclosure and an approach of root cause analysis of errors with a view to health improvement. And DHBs, sir, have been very willing partners in this, and have had concerted efforts, both individually and collectively, to improve accessibility, acceptability of services, effectiveness, efficiency, and above all, safety of health services. So I think this new commission has the potential to move that on to a next stage, and I think that's a good thing. If I could sound a note of caution, Mr. Speaker, it would be that in providing this greater central capacity to coordinate and steer quality improvement, it is really important that we do not end up disempowering those who are working at the coalface on quality improvement, because it's really at that level that the big gains can be made. And it's critical that the Commission gets that balance right. The bill also provides the machinery for requiring collaboration between DHBs. And I guess from the beginning of our current iteration of health sector organisation, there's been debate around how many DHBs there should be Ian Lees-Galloway has just spoken about that issue. The fact is, Mr Speaker, that whether it's 21 or 20 or 10 or 1, that number will be the right number for some things and the wrong number for other things. In broad terms, the tension is this. The more local services are organised, the more sensitive those services will be to local need, and actually the more innovative those services are likely to be. On the other hand, the bigger the unit, the greater the potential is for economy of scale and for coordination of highly specialised services. So those are the tensions. And the trick, of course, is to find a system where we can base our health services organisation at local levels, but then have the capacity to aggregate up where that's appropriate. And that's occurred already quite a lot in the health sector, as others have mentioned. But the basic problem is one of asymmetry of need, that in general, a smaller DHB, and I have some experience in this area, Mr Speaker, a smaller DHB will have need of the collaboration where a larger DHB may well not. And one of the obstacles to progress on that issue has been the wording in the current Act that actually requires DHBs to act in the specific interests of their people and their region. And what that means, sir, is we end up only getting collaboration occurring between DHBs when it's to the universal benefit of all. And that means situations where most people would benefit from closer collaboration do not necessarily result in that occurring. That is a problem that we must fix, and I think this bill provides the machinery and the mechanism to fix that. I guess that the other important aspect to this is another one that Ian Lees-Galloway touched on, and that's the solution that some have advocated of amalgamations, either encouraged or forced. And certainly, sir, that is not a solution that I favour. I favour instead the idea of an intelligent network of smaller DHBs, or DHBs perhaps around the same size that we have now, that have good mechanisms for collaboration. Because I think that while amalgamations do have some potential to fix that central problem of collaboration not occurring, they have some costs. They have the cost of the change itself, and they also have the cost of the loss of innovation. And I think those are costs that we would face at our peril. So, sir, we support those two central thrusts of the bill. I would say, sir, that in relation to collaboration, that it's a shame that that same approach is not being adopted in relation to primary health organisations, because exactly the same dynamics apply with primary health organisations. The Ministry of Health undertook some analysis of what's the right size for a PHO a couple of years ago, and they found that small PHOs and big PHOs both have strengths and weaknesses, and so they couldn't come up with an optimum size. And actually, sir, a smart solution to that problem would be better than the Minister's intent of requiring PHOs to amalgamate. There are other changes in the government's response to the Horn report that we supported. One of those was the change to Pharmac's role, expanding that into medical devices. It's not in this bill, but actually as I read the Act, it doesn't require legislative change to facilitate that. And so we're confident that that's still on track. We also support the change to the role of the NHC, and the National Health Committee, and I'm reminded of Gareth Morgan's recent book, where he talks about that fundamental problem that every health system in the world faces of potentially unlimited need. And his solution has two elements. He says one of the things we need to do is to prioritise health spending, and the change to the NHC facilitates that. And the other is to actually prioritise expenditure and investment in public health and primary care. And so it's unfortunate that the Minister has